We're here in Silicon Valley, and we're the hospital of Silicon Valley. So tonight's webinar was developed by myself and many experts, including my friend, Dr. Sari Levine. I'm Barb Dean. I'm a women's health nurse practitioner, and I earned my master's degree at UCSF. And I'm also a certified menopause practitioner by the North American Menopause Society. And tonight, it is my great pleasure to welcome Dr. Sari Levine, a board-certified urologist who is in private practice right here in the heart of Silicon Valley at El Camino Hospital. Dr. Levine is a graduate of Stanford University and completed medical school at Washington University in St. Louis. She completed her internship and urology residency at the University of Pennsylvania. In addition to being a practicing urologist, Dr. Levine has also been chief of surgery and chief of the medical staff here at El Camino Hospital. I refer so many patients to you, including my own son. So thank you for joining us, Dr. Levine, and welcome.
Well, I'm delighted to be here to talk about women's health issues. And Nurse Barb, since we are definitely friends and colleagues and we've known each other a long time, please feel free to call me Sari.
Well, I really appreciate that. We want to respect your education and your accomplishments, but I really appreciate that for tonight because we're having a conversation about women's health. So before we get started, here's a few details about tonight's webinar. So we're going to talk a little bit about housekeeping. And you probably, when you signed on, you found that you have a control box. So if you haven't already downloaded the handouts, then you can go to the handout section of your control panel. And there's a link there that you'll be able to find. We also recommend that you download the Family Personalized Health Management mobile app. This is free of charge, and it can help you manage your personal health information as well as your family's. You can also find a link for that in the chat box. So here you see the Family Health app. This is offered to you by El Camino Hospital, and you can find the link for that in the chat box. So I'd like you to take notes throughout today's session. We're going to have a lot of time at the end for questions, but if anything comes up for you, go ahead and use the chat box to type them in. We will get to as many as possible at the end. And I want you to stay with us because, Sari, guess what?
What, Barb? Please tell me.
Well, you know what? We have a contest, and you could win a Tory Burch handbag. And I want to remind you to wait till the end of our webinar. We're going to have an email that's got a link to all kinds of resources and valuable tools that we'll send to you. So, Sari, you know, a lot of women see both of us, and they have a lot of questions about their changing bodies, especially at midlife. And I think we've done a lot of workshops here at El Camino as well. And so many times, both of us hear that women have been brought up to keep certain private matters to themselves and also to make sure everybody else in their family, their neighborhood, and their friends get taken care of. And they often put themselves last. But tonight, that's different because tonight we're going to put ourselves first, and we're going to talk about a lot of common midlife health issues, the latest research and advancements. We're going to talk about how to keep some of those midlife challenges that maybe are a little bit taboo and we don't want to talk about, but let's talk about how to keep them from negatively impacting how you live. And again, we've got resources at the end.
I think what's sad in a way to me is that many women are really surprised to learn that they're not the only ones who have worries about breast changes and cancer detection, who leak urine and have what we call incontinence, and that there might be something to do about it, and really that have pelvic issues including pain, irregular bleeding, and of course, something Barb and I have talked a lot about, and I know that women really want to talk about it, but aren't usually brave enough. Sex. We talk about it so much in other ways, but we want you to know that we're here because it doesn't need to be painful to have intercourse after menopause. Intimacy is important to you and to your healthcare providers. And if it isn't, then let's know what the options are and have other solutions.
I know that once we start talking about sex, that's what people want to hear about. So you don't want to miss that. Um, we have a poll here. We want to hear what your top concerns are. So we're going to launch a poll.
And here are the questions as you see them. What's your top concern? Screening for breast cancer, leaking urine, pain with intimacy, all of the above, or something else? And if you answered something else, then send us your questions or concerns in the chat box.
All right, so as we wait for the results of the poll, let's dive into a topic that a lot of my patients are always asking about. It seems that every day we hear some new guidelines about when women should have a mammogram. It's so confusing.
I'm so glad that you're bringing this up, Barb, because I don't recommend mammograms. I defer to you and your colleagues. What is it that you're going through to recommend to your patients?
Well, every woman's situation is different. And so I and most of our colleagues in OBGYN, we like to individualize care based on a woman's own unique history, maybe her family history. And in general, I recommend mammograms, including 3D mammograms, which are known as tomosynthesis, every year. And for women who have dense breast tissue, I have them start with a screening mammogram and then have what's called a whole breast ultrasound, or ABUS, automated breast ultrasound.
So this slide that you're looking at with us shows, well, used to show, the reason why we have a gap is because we have the poll to talk about.
Okay, so we're looking at what is your top healthcare concern, and it looks like
Incontinence is probably the biggest hitter, and we're going to get to that in just a little bit. But some of you really are concerned about the screening criteria for breast cancer, and sex, of course, is something we'll talk about too. So all of the above is inclusive, and I know that at least a third of you want to talk about it all, and so do we. So let's get started.
oh my gosh, so we're really talking about everything you want to hear about. Cool. All right.
So
So we are moving our slides.
right. So the slide that you initially saw, there was our very own radiologist, Dr. Gita Sila, who reads mammograms. So Barb, what do you say to a woman who might be concerned about radiation exposure with mammograms?
I'm so glad you asked, because so many patients ask me this every single day. So the new technologies such as 3D tomosynthesis mammography, they actually lead to reduced amounts of radiation exposure. And that's because these newer technologies provide more accurate visualization. And I know a lot of you have had lots of callbacks and you've been asked to come in for magnified views. What happens is that using the new technologies, such as 3D tomosynthesis, reduces the need for those callbacks. Now, I want to put this into context because all of us are exposed to radiation throughout our days, every single day, from our surroundings. But if you look at the amount of radiation a woman receives from a 3D mammography, it's about equal to what she would receive from going on an airplane flight from San Francisco to Chicago.
That's really crazy, Barb. Isn't it funny how we worry about things and when you put it into context, that doesn't seem so scary anymore?
And you know what? I had to look that up because I was worried about it.
See, so that's what we're here for. We're trying to make you worry only if you really need to. You know how your mom said, I'll give you something to worry about? We'll let you know.
Oh my gosh. Well, so it's important that women know what screening technologies are available, because every woman's situation is different and we need specific tools for specific women. So for me, it's very reassuring. when I screen someone who may be of Ashkenazi descent and she may need MRI more frequently, or a woman who might have increased breast density, I know that here at El Camino, we have personalized assessments. Again, we have 3D tomosynthesis, we use whole breast ultrasound, and we have MRI should it be needed. So I want to ask you, Sari, why is it important that our breast center here have all of the different breast screening technologies?
So my job here tonight is to sometimes kind of reconfigure what you've told me, because I'm learning as you've talked to me too. And what I'm hearing and what I want everyone to remember is, as a physician, I know that no two patients are alike. Tonight, no two women are alike, and especially no two breasts, let alone different women's breasts are alike. And that's why having different options allows us to provide different diagnostic options. So many women really are surprised to learn that increased breast density is a risk factor for breast cancer. And you can't tell by feeling whether or not your tissue is dense or not. So that's going to be something that your provider is going to have to explore based on your old mammograms and any other history they might get. And there are certain women in our demographic community who are more likely to have dense breast tissues, and that includes women of Asian descent, Chinese, Vietnamese, and South Asian, for example. So for women who have increased breast density, a whole breast ultrasound is recommended after the mammogram.
But you don't have to be of Asian descent. I'm of Italian descent and I have increased breast density, and that's why we start with mammography. And if we need to, then we move on to whole breast ultrasound. All right, now hold on to your hats here, because this is our fun contest that we talked about at the beginning. We have Project Pink, and there's a link in your control panel. So, here at El Camino, our breast health experts encourage regular mammography after age 40. But the truth is, with Project Pink, there's a little bit more to it. So not only will you promise, if you sign up for Project Pink, to have your annual mammography, you're going to receive a lot of things from El Camino, including some relevant health bulletins, health events like the kinds you and I go to and the kinds that we moderate. There'll be lectures, webinars, and more. And again, you can go to your chat box and find that link. And when you join in October, you're going to be entered to win a Tory Burch McGraw leather tote, which is, I think, a $398 value. Just guessing on that value.
But not 50 cents extra.
That's right. And you know what? I had my mammogram already, but it's still October, so I think I might enter. What about you?
Me too. I just had my mammogram, and so I deserve a chance at this beautiful tote.
I think so. Cool. So we're going to switch gears now. We're going to talk about an issue that many of you are concerned about, and that is, in midlife, a lot of us are going through perimenopause. Well, what is perimenopause? Well, I kind of say, in an offhand, kind of joking way, that it's a magical time in your life, and that's the time in your life when you go from regular, predictable periods to having no periods at all, which, as you know, is menopause. But during perimenopause, it is a hormonal roller coaster where women might be having hot flashes and night sweats, trouble sleeping, even a little weight gain. But one big issue that happens now is that about half of women will have irregular and abnormal bleeding.
So what is abnormal bleeding? I think it's really important for women to know just when they need to be concerned. Like I said, my mother will tell you when to worry. Well, my mother can't, so you have to find the way to decide when to be concerned and when to call your healthcare provider. So now we want to help you through that. So you should see your provider if you need to wear pads and your pads are drenching with blood and you have to change them more than once an hour for more than a day. If you're bleeding longer than 7 days at a time, you don't have to. You need to talk to your doctor. Your periods are coming sooner than 20 days apart. Again, that's when you seek counsel, you get help. And if you have any bleeding that occurs after you've been through menopause, when you are no longer getting periods, and you're not supposed to have any bleeding, it's really time to talk to a doctor.
You know, I think
Or, I'm sorry, because that's kind of rude. There are so many different providers at different levels of expertise, and you just need to find the provider, not the doctor, but the provider that serves your needs.
you mean like a nurse practitioner?
Yeah, like I had
Or
my own daughter see Nurse Barb, so you know that we trust all levels of expertise.
thank you so much. So there are nurse midwives, physician assistants, nurse practitioners, and then there's those physician friends too, right?
Absolutely.
You know, I think a lot of women put up with a lot of things, right? We put up with so much bleeding, and of course, we always put ourselves last on the list. But sometimes women are experiencing abnormal bleeding. They know it's abnormal, but they don't want to bring it up with a provider. Why do you think that is?
Well, we talked a little bit about it already tonight, and I really do think that fear drives a lot of bad decisions. Women are afraid, everyone's afraid of what things might be, and as you get older, maybe it's bad, and now you just don't want to know about it. And with bleeding and with women's stuff, I think women are really concerned because any questions their mothers or grandmothers had, they ended up with a hysterectomy and surgery to remove their uteruses, and women are afraid that that's going to be it. So how do we diagnose? So Barb, I know you work with a lot of women with abnormal bleeding. Walk me through how you diagnose the problem.
Well, as you can see from this slide, we use a lot of different imaging, including ultrasound, hysteroscopy, MRI, and endometrial biopsy. And the most important thing for you to remember is that if you're having any bleeding at all after menopause, once you've finished with your period, you haven't had a period in over a year, any bleeding, that means you talk to your healthcare provider because we need to find out if there's a precancerous or cancerous condition going on. With an endometrial biopsy in my office, we use a local anesthetic, so this minimizes any discomfort. So we use imaging to look for the causes of bleeding. So, Sari, I've got a slide up here that I use all the time that shows polyps and fibroids, and these are structural causes of bleeding. Sometimes bleeding is caused because a woman is not ovulating. So can you tell us a little bit about what a polyp or a fibroid is?
So polyps and fibroids are both small growths, and they're usually completely benign. It's just where they're located that makes them a little different. You'll see on your picture that the polyp looks like it's more in the middle in a cavity. That's inside the uterus, and the fibroid grows more in the wall of the uterus. They behave a little differently, and there are a lot of different treatments. What do you usually recommend, Barb, when you have patients who are found to have bleeding from polyps or fibroids?
Well, you know what? I had a polyp and I had a hysteroscopy. And that means that I had a small tube that went into the uterus and they removed it. They could just remove the polyp. We also have minimally invasive surgery that removes just the fibroid or just the polyp and does not require hysterectomy. There's also medications, IUDs. The point is what you want to do is not let fear prevent you from having the conversation because there are so many different treatments available now that were not available when your mom and your grandmother were younger. So we're going to switch gears again. I want to ask you, does this look familiar to any of you? You know, we're talking a lot about women's health issues that are embarrassing and taboo, but I think urinary leaking is one of the most embarrassing things that women come in for. Nobody wants to smell like they have some urine, and no one wants to admit that when they cough, sneeze, or laugh, that they're leaking, or that they have such a sudden urge, they feel like they just can't hold it. But women, you're not alone if this is happening to you. 10 million women have issues with leaking urine, and they're relying on pads when they really don't have to. And I know pads are a big hot button issue for you, Sari.
Well, of course, Barb, I never want anyone to wet their pants, but I also don't want to rely on pads. Now, we're going to interrupt because we have a poll for you, and we want to get a little more information from you. So I want to ask you a few questions to help us figure out whether or not incontinence, that involuntary leakage of urine, is an issue and how we can assess it. So, do you know where every clean bathroom is in 5 mile radius?
I do. I actually do.
Do you avoid exercise, jumping, and playing because you're afraid you might leak? Do you pop up like a ping pong ball all night long to go to the bathroom? And are you wearing panty liners or even thicker pads because you leak? So if you answered yes to any of these questions, then we're going to give you some information. It's just a little bit, it's just a start. We're going through things very quickly tonight because we don't expect to answer all your questions. We just expect to give you an idea that your questions are valid and that you can get better information if you seek answers to those questions.
So yeah, it's kind of a way to start the conversation, start to say, okay, this might be happening. Now what do I do, right? Because there's so many different options now. Women don't have to spend a fortune on pads. And here at El Camino Hospital, as you're going to see, we have a ton of resources for you. So when we talk a little, as we're waiting for these poll results to come in, I want to just remind you that in the handout section of your control panel, you're going to find links to a lot of resources, including a detailed pelvic floor self-assessment. So we're going to talk a little bit tonight about why do women leak? What's going on, Dr. Louie or Sari? What's going on?
Okay, so why don't we try and see? We're going to stop for 1 second just to see if there have been enough answers to the poll to reflect on that for a second.
Okay, great. We do have some answers here.
We do, and it looks to me that getting up at night is a real problem, and wearing panty liners for leakage, which isn't specific, really is important. So I want to try and explain a little bit about what we think about when we're talking about leakage of urine. So the important thing to understand is that incontinence is a symptom, not a diagnosis. And so the first thing that we as providers need to sort through is what's the real cause. So if you've had a bunch of babies and your muscles in your pelvic floor kind of don't support the bladder where it belongs anymore, then when your bladder gets full and you cough or you sneeze, you leak urine. But that's a different issue than if you can't hold it long enough to get to the bathroom, or just as you see the toilet, you start to pee a little bit, or you've been out all day, you come home, put your key in the door, and you squirt a little urine. Those are different issues, and treatment is different. So it's really important to be as accurate as you can be about what's bothering you and what provokes the leakage, what makes it happen. So when you come to talk about it, we get a better sense of what the real issues are.
Why should women overcome their embarrassment? Is it is it because you actually can help, or are you just going to pat them and say, go buy more pads?
I can't tell you, Barb, how many women come in and say, you know, my doctor just said I just have to live with it. Well, that goes back to, I suspect many of you know the wonderful actress Carol Channing. And in her later life, all I know is that I saw her on TV for Depends pads. And she was just extolling the virtue of these pads. And all I would do, and my kids would leave the room because they would know I would scream at the TV and say, talk to your doctor. Because there's so many times that we have lots to offer that may not eliminate the need for that security of a pad, but that we want to make it so you understand and have things to do that you don't need to worry and avoid things because you might leak urine.
Well, that brings up a really important point, because if you've been told that you just have to live with this, or you're not getting the information that you feel you need, it might be time to consider finding a different provider who you can work with. So you can talk to your friends, you can ask coworkers, or you might use the Find a Doctor link on the El Camino website. Now, before you go to your healthcare provider and you're talking about leaking, let's talk about what you can do to be more prepared.
So I really respect that my patients wait to see their doctors and or their providers, and they've had appointments and they really want to get to the bottom of things. So the more information that you organize and bring with you, the faster and clearer the path to an answer may be. So before you come to an appointment to talk about incontinence, it's really important to organize what your behavior does to contribute. So we're going to show you a sample of a bladder diary. What time do you wake up in the morning? What time do you first drink? What is it that you drink and how much do you drink? When are you urinating? Did you leak with that urination or not? Was it a little leak or a big leak? Do you have a strong urge to urinate or do you just go kind of routinely? Is your activity related to your leakage or the urge? Then what time is it that you went to bed and how often at night? And if you can, what time did you get up at night to urinate? So if you take 2 or 3 different 24-hour periods and document what it is that you do, how much you drink, what kinds of fluids, and when you urinate and when you leak, you will be so far ahead in the conversation when you meet with your doctor that we may very well get to several different answers in that very first visit.
Well, as you can see, this bladder diary, Dr. Levine and I put this together as we were developing the webinar. And after tonight, you will be sent a link. So if you need a bladder diary, you get the link, you can download it and print it for yourself. So, you know what? I send a lot of patients to the pelvic floor strengthening classes here at El Camino Hospital. I know you were instrumental in starting those, and you've been such a champion. So, can you talk to us a little bit about the benefits of these classes?
So I'd love to because I am thrilled that we have resources that are not surgical. They give women a sense of control over some of the things that might improve how they urinate. The important thing to understand about the pelvic floor is if you imagine there are muscles cradling and holding the bladder in the bottom of the body or the pelvis as we describe it. So sometimes what one needs to not leak urine is to be stronger, to strengthen those muscles. So when you cough or sneeze, the bladder doesn't drop out of position and let urine leak out. But sometimes those muscles are so strong or tight that they're squeezing on the bladder and not allowing the bladder to fill normally. And when you go to pee, the bottom of those muscles are tight and it's like trying to urinate through a closed door. So you feel a strain to urinate in a slow stream and it's hard to start. Or it's just the squeezing makes the urine come out even more. So you think that you should be strong and able to feel the urge to urinate and tighten those pelvic muscles and keep the urine in, but in fact, you're actually making it worse. You make urgency worse if you're too tight and strong. So part of the pelvic health program is teaching you when to engage and strengthen that pelvic floor, but when also to disengage it to allow the bladder to work more normally.
Oh, I'm so glad you explained that because sometimes people think they just need to do more Kegels. So, here's a quick question. If I come to this strengthening exercise class, do I have to take my clothes off?
Absolutely not. So the great thing about the pelvic health programs, they're a little bit of introduction. They give you the simple concepts and maybe some simpler exercises. But if we really think you've got more of a problem with spasm of your pelvic floor and one-on-one physical therapy is going to be more beneficial, that's when the level of intimacy with your therapist seems to go up. They're lovely women and they're trained. And yes, the best access to your pelvic floor is through the vagina. So guess what? Hard to do that virtually with your clothes on, but that's a one-on-one session. Like any massage therapy, you would be more comfortable in that setting if you didn't have your clothes on. But in those classes at the hospital, when there are more than 2 people in a room, absolutely not. It's just getting used to being taught how to strengthen those muscles at home.
Also, this slide shows you some of the things that are available through the pelvic health program at El Camino Hospital. And what I like is there's a personal assessment, so women who need more individualized, personal, private treatment can have that. And I would just invite all of you to check out the website. There's also a really cool physician referral service with 65 different doctors on the pelvic health panel. Not only do we have pelvic floor physical therapy, but there's diagnostics, including imagery, imaging, and laboratory. So what we know is one size never fits all. And I just want to reiterate, you can save a lot of money by not buying pads and heading over to the pelvic floor strengthening classes if that's what you need. But you may need to see a provider first to find out what the issues are. So we are going to talk a little bit about an issue that absolutely contributes to urinary leakage. And I think a lot of women are surprised by this. You know, when we go through menopause, we have a drop in our estrogen, and we have more estrogen receptors per centimeter or per square inch in our vaginas and vulvas than anywhere else in our body. So as estrogen levels drop, all over. We might have hot flashes and night sweats. We're starting to get more vaginal dryness, irritation. You might have noticed less natural lubrication with sex, and you may have also noticed some pain. Now, unlike hot flashes and night sweats, which, you know, they can get better over time, this condition never gets better. In fact, if it's not treated, it only gets worse.
So with lack of estrogen, women notice their vaginas seem smaller. They don't stretch like they're expecting or that they used to. The skin is thin. They feel that the tissue may and even often does tear with penetration if you're having penetrating intercourse. There's less flexibility or ability to really relax and quote unquote enjoy it. And painful intercourse is something that interferes with a couple's ability to be intimate because he doesn't want to hurt her, but he doesn't understand. She doesn't want to admit it. And so that's why we want you to know there are so many different treatments, even without committing to hormone replacement therapy, systemic therapy. So this isn't, we're not talking about you taking on the risk of breast cancer or heart disease. We're not talking about treating your hot flashes or even, sadly, your libido. That's a separate decision you make with your providers. But this is for all comers who have chosen to have hormone replacement or not, the vagina needs more help. It doesn't get enough estrogen from that replacement to avoid the dryness and the loss of elasticity or flexibility that most women will encounter at some point after they go through menopause.
And you know, for women who may have a female partner or women who have no partner and maybe they're self-sexual, they can have a lot of vaginal dryness. Even women who are not interested in sex at all, sometimes the vaginal dryness means that they're going to have pain just wearing their underwear or when they exercise.
And it's not even just that, because when the bladder sits right on top of the vagina. So when the vagina is thin and irritated and loses estrogen and gets very thin, the bladder can be much more irritable as well. And that can contribute to urgency and the need to urinate too frequently. And the urethra, the opening to the bladder, is in that part of the vagina that loses estrogen. The tissue around the opening gets thin and pulls back. That urethra gets exposed. There can be spotting on your panties or a pad because that urethral opening is bleeding, and it can contribute to a lot of irritation. And it takes away a lot of defense against urinary infections. So all of those things become much more challenging because the vagina itself is dry and inflexible and the tissue changes.
Wow, so it's all really related, isn't it? And I want to just let everyone know that there's so many different treatments available, from over-the-counter vaginal remoisturizers and lubricants to prescription medications, then laser treatment. And the goal of treatment is to go from the Sahara to a rainforest. We want the vagina to be moist and we want it to have some flexibility, and not just for sex, although that's a great reason. When women have a moist vagina, it's healthier and they're less likely to have odor. They're less likely to have urinary tract infections. Now, you're not alone if you have vaginal dryness. Don't just grin and bear it. Again, doesn't get better over time, it just gets worse. So let's talk a little bit about something that we talk about a lot when we get together at some of these women's health webinars. Um, with sex, I think it's about 50 to 70% of women over 50 need to use a lubricant for sex. And sometimes my patients come in and they say, well, I just thought it was because I wasn't aroused or that I was angry with my partner. And they're usually relieved to understand that a lot of women need to use some type of lubricant. Um, but sometimes no amount of coconut oil, which it's kind of like taking a trip to the tropics without the cost of an airplane ticket, or using olive oil or even baby oil or some of the over-the-counter lubricants. Sometimes, no matter how much you use, it's not going to help. So I want to talk a little bit tonight about one of the more recent advances, and that is using laser treatment. And some of us know that as the Mona Lisa touch. That's used for vaginal dryness. So, Sari, can you help us understand this better?
I'd love to. So what I tell my patients is the Mona Lisa touch started in Europe, and I'm sure it's because, and it was developed by an Italian guy who I'm sure did it because his wife wouldn't let him near her. Because vaginal dryness, no estrogen, not a chance, right? So what was done is a standard laser, CO2 laser has been used for the skin for years and years, was adapted to allow us to treat the vaginal tissue. And what that does is imagine thousands of tiny little holes driven into this thin, fragile tissue. And in order to repair itself, new blood vessels are created and the tissue thickens and it becomes more elastic. So this is one of my favorite pictures because the picture on the left is a post-menopause picture of the vaginal lining, and that very thin, dark layer at the top is actually the vaginal wall, and the paler tissue below it is what happens to the tissue underneath it, and it doesn't have the vibrancy to stretch, and it's not folded and thickened like it was before menopause. So the picture on the right is after one treatment of this series of 3 typical treatments to use the laser, and that's showing you that the lining of the vagina has thickened again and is starting to recover that folding and support and thickness that's healthier. So the laser treatment, the process and protocol is an internal and external probe that delivers these laser beams and creates this treatment. And we usually will do a series of 3 treatments, 6 weeks apart. Sometimes with my patients, I'll use a 4th or a 5th treatment for the outside tissue, which is where it feels like you're going to tear and where it needs more help. And so you understand, I was patient number 1 in my office because I felt like if I didn't know what it was to do, then how could I possibly describe it or use it? And so I recognize limitations. Sometimes that bottom tissue of the vagina that just wants to split in 2 isn't perfect after the laser, but the canal, the inner lips, that what we call the labia minora, they respond to the treatment. So there's more natural lubrication, more elasticity, it stretches. It really addresses the dryness, discomfort, irritability that women who have lost estrogen to their vaginas experience.
And I see so many breast cancer survivors, and because using the laser is completely hormone free, I recommend it to them. And I have seen from your patients and my patients that many women who've had the laser treatment are now able to have satisfying sexual experiences without pain. So I've got a picture here of what it actually looks like.
And this picture is a little intimidating, but it is to perform the procedure requires two separate probes. The one that you're seeing is one that looks like this big metal penis, and the tip has an angle with a mirror that deflects the laser beam so it can treat the vagina in a circle around the whole vaginal canal, and then the external tissue is treated separately. And the whole procedure takes, in my office, you're there about 20 to 25 minutes because I numb the outer tissue with a numbing cream for up to 15 minutes. The procedure itself, both components take maybe 5, and then I put a little cold pack on at the end, so you're there for another 10 minutes or so. It's very easy to tolerate. I happened to the first treatment, I was on call and was in the operating room till midnight. Noticed a little throbbing, but it didn't prevent me from working, and there were no issues. So it's very well tolerated. Someone might wonder about anesthesia, but really that numbing cream is more than adequate, and it's a well-tolerated procedure that has a lot of benefit. So that's certainly one of the more modern and newest options that don't involve the expensive hormone cream and other issues. Now, it's not unfortunately it is not covered by insurance. So one does have to prepare. It's not inexpensive. The cost varies between providers and is adapted certainly in my practice based on your needs and whether you're an established patient or not. But one can expect to pay anywhere from $2,000 to $3,000, I would expect, and that should include the initial treatment series of 3 to 5 treatments. There's the need to refresh it, just like any skin treatment that one might encounter, that at about a year, could be 9 months, could be 15 months, if dryness starts to become an issue again, then one refresher treatment is usually compelling and recommended. And so that again is individual, and we work that out patient to patient.
Wow, that's so helpful. I think people have so many questions about this, and there's so many myths and misconceptions, especially when people hear different terms for this. But I recommend it for my patients. I know you do as well, because we've seen the results. I've also seen a lot of the data, and the data is very compelling. Um, wow, we covered a lot tonight, Sari.
You know, that's the sad thing for me, Barb, is always that we could have this conversation for hours. And I know that we touched on a few things. We didn't always get to and delve into questions that are really important to the people who signed up tonight. But it's a taste, it's a reminder, it's that we're here. There will be more events, there will probably be more webinars. We'll get to more specific things the more we learn about what people are interested in.
Well, you know what? We had a lot of questions coming in, but before we start with the questions, I want to let all of you in the audience know a couple of things. You're going to be receiving an email after this webinar with links for that list of resources and personal assessments we've been talking about. We've covered a lot tonight, and so I'd love you to do the survey that will be sent to you right after we end, because that'll help us design more in the future. Now, what I'm going to do is, while we take questions from the audience, I'm going to put up a resources page for all of you so that you can see like how to access a lot of those things. Well, we're going to try to put up that resources page for you. That'll include the Project Pink, how to find a doctor, the Family Health app. We're going to send you the link to the Bladder Diary. There'll be more information on pelvic health classes. And you'll also find Dr. Levine's office phone number if you'd like to make an appointment. And I'm going to ask you to follow me on Twitter and Facebook. You can follow me at Nurse Barb Dean, and Dean is spelled D-E-H-N. So let's start with a question. What I want to know is, Sari, if I have a patient who needs laser treatment, do you use anesthetic for that?
So what I was trying to describe, it's funny, I laugh because the name of the anesthetic cream we use is BLT. Now that takes us someplace we really wouldn't want to be, but that's a combination of short and long-acting pain medicines in a cream that we put on the external surface of the vagina, and that's enough to make it so that the laser doesn't hurt.
Cool. Wow. So I have another question. This came up with a patient of mine. She gets up in the morning, but before she gets up, she puts a washcloth between her legs and she runs to the bathroom. And she's had this for 10 years, but she was told by 3 different providers that nothing could be done.
So, Bart, that's really interesting because you know what? She may have seen me and I may have told her about the washcloth because sometimes if you try and over-treat at night, the best treatment is to wake up more frequently because the bladder just has gotten too full. So, of course, I would first say try not to drink so late into the evening. But if you're dead asleep and your bladder's filling, and when you wake up, everyone will need to urinate first thing. But if that bladder has had a longer period of time to fill, then it just may be too full to stop the urgency. So, of course, there are things we might be able to do to make it better. But if the only time someone has urgency or difficulty getting there fast enough is first thing in the morning, a washcloth may be better than medicine or having lots of exercise programs and everything else when if you just urinate more often during the day, we don't have that same problem.
So our moderator, Marie Alexander, she's going to ask us some of the questions that are coming in from the audience.
Well, there was one that came in right after you were talking about the laser treatment, and they wanted to know if you use the different power on the laser treatment for different parts of the vagina that may be thinner or the variances in the vagina.
So we start, the answer is yes and no. So the vaginal canal, even if there are differences in depths, it can withstand the same power through that short treatment period. But the difference between the first treatment and the second and third is that once we've treated first and we've broken into and started to create a healthier space, then we want to actually penetrate even deeper. So the power we use the first treatment in the internal probe is different than the power we use the second one. We then decrease the power for the external tissue because it's not as accommodating, and so we adapt and alter that as well. If patients have very sensitive external tissue, there's even a lighter setting to protect them. So again, yes and no. We don't need to vary the power between the deepest part of the vagina and the middle of the vagina and the outer part, but we do change the power between treatments and if we're treating internally versus externally.
And I think that it really speaks to why you should see a trained healthcare provider for this, because you can't just go to anyone and you don't want to be going to a dermatologist to treat that part of your body.
One question that came in was you talked about menopause. What are the symptoms of menopause and how long does it last? And then a follow-on question to that was they were asking about what about hormone issues?
Okay. Well, the symptoms of menopause are that you don't have a period for 12 months. So that's just one day in your life, right? When you have not had a period for 12 months. The following day, you are postmenopausal. And many women will have hot flashes and night sweats. They'll have vaginal dryness. They may have aching in their joints and their knees. They may start to see more urinary incontinence. We think that the symptoms of menopause can last between 3 and 15 years, though I have patients who are in their 80s and are still having hot flashes and night sweats.
And don't forget that one thing I think that's underestimated is a change in the clarity of thinking. So sometimes menopause can affect your sense of how to do your job and how to get to the next thought. And so there can be extreme symptoms and there can be mild symptoms. Expecting all women to just suck it up and get past it may not be appropriate. So don't feel that just because the newspaper says there's controversy, that your provider can't define and develop a program that's specific to you and your own risk. Do you have a risk of breast cancer? Do you have a risk of heart disease? That may change the recommendation, but it's individualized.
Well, I think a lot of women have a lot of sleep fragmentation. That's kind of a fancy word for saying they have interrupted sleep, but they may not be aware of that interruption. They may not have a night sweat that wakes them up, but we know from really good basic research that they're having disturbances in their slow wave or delta wave sleep, which is another way of saying there's a lot of disturbance in your restorative sleep. So you may wake up exhausted and think, well, I slept through the night, but there's some sleep disturbances there. That's why if you're looking for help at menopause, go to menopause.org. That's the website for the North American Menopause Society. Find a menopause provider who's certified. We have another question.
Yeah, we have a number of them. Can there be negative outcome to the Mona Lisa procedure? What are the risks that I'm taking?
So I've been performing the procedure for several years now in my office.
And the good thing is this is not new technology. It's a little bit of an adaptation of technology in order to treat the vagina. So the risks would be if the tissue around the urethra is compromised, if the laser is used too close to that urethral opening, so we're aware and careful. It's a burn to a certain extent, so the immediate response is that it can sting and you need to protect the tissue until it's well healed. There has not been, in my experience or in the studies that I've reviewed, any permanent damage or outcome that is of concern. It's a very safe technology. It's a very superficial one to a certain extent, and we've not seen the laser penetrate deeply enough to damage any other organs. It's just kind of operator dependent, making sure that the tissue that's being treated can accommodate it and that you protect the urethral opening, which is very nearby, so that it itself isn't injured in the treatment process.
The next question we have here is, does menopause affect the GI tract also? Does it contribute to rectal leakage too?
That's a really interesting question, and I don't know that I would blame poor menopause on that, but pelvic floor dysfunction can contribute, so that women who have urgency and urge incontinence, that means they get a sudden awareness they need to urinate and they're urinating before they can even execute a travel to the bathroom, can have a very similar experience with with stool and their rectum. So they get a sudden fecal urgency and have leakage as they try and get to the bathroom fast enough. And so those are intertwined, and sometimes treatments are very similar, treatments for one, treatments for other, but those are not just because of menopause. It's just a lot of things change. It can just be that the pelvic floor is changing, and that's an easy answer, but there may not be such easy answers.
And you know how we have the bladder diary? Well, you can adapt that if you have any rectal leaking. And that's what I ask my patients when they come in. What are you eating? Right? Are you having a lot of coffee? How often does it happen? And often we can help rectal leaking with just a few minor changes in diet. And if I can't, then guess what I do? I refer on to a specialist.
Right. So these are not things we expect to be able to answer over the phone or computer, but having your provider help you is important because things usually can be made better.
Okay, well, I think we have time for a few more questions here. One of our friends online says she feels like she's Austin Powers. She wants to know, is it normal to take longer to urinate with a restricted flow after you are perimenopausal or postmenopausal? What can be done about that?
So easy answer, hard answer. It can be harder to urinate if the vaginal tissue has gotten weak and the muscles have separated and the bladder's dropping out of position. It can be kinking itself and there may be bulging. We call that prolapse. That's a different issue than if the pelvic floor is actually in spasm. And remember, I talked about the muscles that wrap around and support the bladder, and they're tight, so you're peeing through a closed door. That can contribute to that sense of a very slow stream and difficulty trying to get started and completing the emptying of your bladder. So I know we're coming to the end of our talk, and I'm hopeful that these questions will be answered for you by seeking the kind of care provider that will listen to those questions and try really hard to answer them. Barb and I have just been honored to be here with you. And I don't know, I'm just the tag along. So I'm going to turn it over to Barb so she can tell you what you really need to know about having been here tonight.
Wow, thank you, Sarah. This has been such a pleasure. And I want to just say thank you. I'm very grateful for your expertise. I'm grateful that I can refer patients to you, and I know they're going to get excellent care. I'm also grateful to you, our audience. You've been amazing tonight. We've had a few technical difficulties, and you've been such troopers to kind of hang in with us. So thank you again. And remember, you're going to be getting an email after tonight's webinar with lots of links that you can access and a survey. So please be honest about it. It just helps us get better and better. So with that, I guess I'll say good night. And thank you again, Sarah Levine, my friend and colleague. And thank you to Marie Alexander, who's been our moderator. And I want to thank El Camino Hospital for putting this together and making it possible.
And thanks to Barb Dean, because without her, none of this gets done.
Well, thank you. Have a great night, everyone.